Thank you to everybody at Iridex, Brian, Joan, Sarah, everyone that's helped with preparing this talk and with MicroPulse at GW. Thank you, Dr. Mathura, for being here, and everyone else that's been involved with this. So today I'm going to be talking about a trial that we are conducting at GW for dry AMD using MicroPulse laser for treatment of drusen. We're going to do kind of two parts here. The first part I'm going to describe this trial, which is now ongoing, and then I'm going to just talk briefly about my experience using MicroPulse as a resident as well. So just a little bit of background. As everyone here knows, AMD is the leading cause of irreversible blindness in people over age 50. 90% of these have early or intermediate disease, which demonstrates drusen in the macula. This can affect visual acuity. However, most of these patients do retain good vision until they progress to advanced AMD, which, as everyone knows, involves the development of choroidal neovascularization or geographic atrophy in the macula. The risk factors of these diseases are many, but the strongest is that there are development of numerous large drusen and the presence of neovascular disease in the contralateral eye. As we know, the ARED supplements can reduce the risk of progression, but there is still a high risk of progression. And because these patients, the number of these patients are growing so rapidly, any new treatment that we would be able to develop for the treatment of this could really impact millions and millions of people. So I'm going to talk for a little while about the CAPT trial, and the reason I'm going to spend some time talking about this is because we really modeled our trial after this trial, which was conducted about a decade or so ago. So since the early 1970s, it's been reported that when laser treatment, laser photocoagulation is done in the macula, it can cause drusen to disappear. A lot of theories of why this occurs, but this has been consistently reported. Now, prior to the CAP trial, there was a pilot study which showed that laser treatment reduced both the size and the area of drusen in the areas that were treated, but also in areas which were remote from treatment. However, intense laser burns were associated with development of choroidal neovascularization, and the reduction of drusen was associated with improvements in visual acuity. So based on this pilot study, the Complications of Age-Related Macular Degeneration Prevention Trial, or CAPT trial, was designed to evaluate systematically whether this prophylactic low-intensity laser treatment could reduce the rate of progression to advanced AMD. This was an NEI-funded study. It was at 23 centers. They enrolled about 1,000 patients over 2 years. And the enrollment criteria involved at least 10 large drusen in each eye with no evidence of advanced AMD. So no CNV, no central geographic atrophy, no serous PEDs. One eye was randomly assigned to laser, and the other was observed. This was a summary of the design of the trial. Included good vision in both eyes at the time of treatment, and no other concurrent ocular disease that would affect the results of the trial. The outcomes, primary outcome was change in visual acuity. Secondary outcomes involved development of CNV, PED, or geographic atrophy. They also looked at quality of life, contrast, reading ability. They followed these patients over 5 years. The eligibility criteria, again, good vision in both eyes, large drusen, greater than 10, within 3,000 microns of the center, no evidence of geographic atrophy, no PED, no other concurrent disease, such as high myopia or other things which might adversely influence the results here. And how did they treat? They used a argon green laser. 60 spots were put in, 100 micron spot size, and they did it in an annulus, which you can see here. That doesn't work. So they did it in annulus from 1,500 to 2,500 microns surrounding the fovea, and not necessarily treating the drusen themselves, but making this pattern around. And as we mentioned before, the drusen would regress even though they weren't directly hit with the laser. So here's a couple photos of treatment. The endpoint was a barely visible burn, which you can see a little bit better in the left. The one on the right may have been treated a little more intensely there. They were followed up after treatment at 3, 6 months, 1 year. They would have repeat treatment if there were still drusen present, and then every 6 months until 5 years. As you can see, this is the percentage of eyes with 50% reduction in baseline drusen. The black is the treated group, the gray is the observed group. And so you can see at 5 years, almost 50% of eyes had a 50% reduction in drusen in the treated group, although there were also many patients that had some reduction even without treatment. The outcome of this, in the end, no change in vision, no change in the amount of choroidal neovascularization. So there are a couple questions about why that might be, and a couple questions that we came up with as to why we should readdress this issue. Okay, so we had a big trial that showed no effect from the laser, but there were some concerns with this. So why is there no effect? One, perhaps the laser itself could have accelerated the development of choroidal neovascularization. Two, were we actually causing geographic atrophy surrounding the laser burns? And three, there was also some foveal deposits that they were accumulated after treatment. Not quite sure where that came from. So what about MicroPulse? So with the 577 nanometer MicroPulse treatment, how does this work, and how can this help us address this issue? So the MicroPulse allows us to localize the effect of the therapy at the RPE without a rapid temperature rise. So the subdivision of the treatment into small pulses allows the temperature cooling in between. And so you can get the effect of the laser treatment without actually developing a burn. So you spare the neurosensory retina, you spare the surrounding tissues. And you get an effective phototherapy without any noticeable burn, noticeable destruction. What about 577? There are many wavelengths, as you've heard about so far today as well. Well, the 577 seems to be the ideal wavelength for the macula, for treatment of the macula. It requires less power than an argon green laser, and the hemoglobin in the choriocapillaris has its peak absorption at 577. So in addition to that, the uptake by xanthophyll in the fovea is negligible. So this really makes it the safe and effective treatment for treating in the macula, which when we're talking about macular degeneration is exactly what we need. And so this would be the ideal laser wavelength for us to develop this trial and this treatment. So our thought was maybe this would allow us to treat the drusen in the same way that was done in the CAPT trial and the trials before, without scarring the retina, possibly reducing the rate of development of CNV and improving visual outcomes. So we designed the trial really modeling after the criteria of the CAPT trial. Our purpose was to test this theory that the laser treatment of high-risk AMD can reduce this progression to wet AMD. This is a pilot trial. We are enrolling 50 patients for this first trial. But if there is a noticeable effect, certainly if we can demonstrate the safety and efficacy of the treatment, then this will help us to begin to start a larger trial. So our hypothesis that it will reduce the progression to wet AMD in comparison with observation alone. It's prospective, it's randomized, not blinded, and a pilot trial. We're going to form two subgroups. So patients that have bilateral high-risk AMD will be randomized in the same way as the CAP trial to MicroPulse in one eye and observation in the other. Patients who have unilateral high-risk AMD will either be randomized to treatment or no treatment. Our inclusion criteria are similar to those in the CAP trial. Visual acuity of 2100 or better, but still the same 10 plus large drusen, clear ocular media, ability to do fluorescein and other imaging. And then I'm just going to spend a minute to go over the treatment algorithm, because this is, as you've heard already today, perhaps there are many different ways that you can apply the MicroPulse. There are many algorithms that are out there. This is what we had come up with for our trial. So there was an initial study by Dr. Saksonov and his group in the Ukraine, who actually looked at this same issue. They treated 10 patients, and the settings that they had used was a continuous wavelength test spot first. So they would use a 200 micron spot, 150 millisecond exposure, and they would test so nasal to the nerve until you got to a mild gray burn. Again, this is in continuous wavelength. So then at that point you would switch to the MicroPulse setting at a 15% duty cycle, maintaining the same spot size and duration, and doubling the power that you came up with the test burn. So double power, 15% duty cycle. In this trial, this pilot trial where they did 10 patients, the safety of this treatment was demonstrated. None of the patients had adverse effects from this therapy. There are no visible burns. The treatment would be in a confluent pattern, and for us, we want to really treat where the drusen are. So basically, we would be creating a grid in that annulus, but we would come closer in as well. As we talked about, the MicroPulse 577 is safe in the macula, and so we would bring it into 500 microns from the center. In the CAP trial, they didn't come closer than 1,500 microns to the center. And we would anticipate that 300 to 400 treatment spots would be used. We plan to follow these patients at 1, 3, 6, and 12 months using all of the imaging listed here, the OCT, the fundus photos, autofluorescence, and the fluorescein angiogram at baseline 6 and 12 months. What we really want to make sure is that we're not doing harm to these patients, of course, and the fluorescein will help us to evaluate if there's any development of choroidal neovascularization in the areas that are treated, in addition to the development of CNV in the center. We're also checking vision, color vision, AMSA grid testing. So if this treatment does prove to be beneficial in reducing progression to advanced AMD, as you know, this could have profound implications on public health worldwide. This room is full of treatments for AMD once it becomes exudative, but we don't have much at the dry AMD point. So this is, we think, a very exciting and interesting area for research, and I hope to be able to tell you 1 year from now about how this has worked. We are enrolling patients right now, and so we'll see. Just a couple final thoughts. Thank you for the privilege of coming to speak to you as a resident, and I just wanted to say a little bit about my experience using MicroPulse, because there aren't a lot of residency programs where it is yet, and so my personal experience is that it has been safe and effective, and as the perspective of a resident, when you're trying to train a resident to do focal laser in the macula, that can be probably a little nerve-wracking experience, and MicroPulse is something that is safe, and so we've been able to, with our residents in doing focal laser, they can do the MicroPulse treatment without worrying about the concerns of, are they going to hit the center of the fovea with it and cause this patient to go blind. So I think that this is it's a good modality for resident training to do laser and become comfortable with the laser. Certainly I've been able to do mini lasers myself, and I think that our attendings that at GW have found this to be a good adjunct treatment. The last thing is that it provided us with many opportunities for research. In addition to this trial, we've also started a trial for CSR. We've had some retrospective series looking at diabetic macular edema. I anticipate that there will be more opportunities for us here. This was one patient that we had really just showed a dramatic and successful response to the MicroPulse treatment. That's it for my talk. Again, next year, hopefully I'll be able to give you the results, and we're excited about that. But I would, if there's any discussion, anyone has suggestions or comments about this, I'd appreciate it. Thank you, everyone.